Let me start. Question to the audience. How many people here manage or have seen or have a patient in their practice that has an artificial sphincter? How many people here, keep your hands up, how many people here place artificial sphincters? That's a big number, and I'll show you why. So the goal for me today is to talk about how I've thought about the artificial sphincter and also spend some time sort of going through some of the essentials, I think, for someone out in the community, as well as people, I think, in academic practice that manage patients with an artificial sphincter that might not be the ones that actually place the sphincter. All right, so here are my disclosures. This is a question that's, though, going to guide, I think, the next 15 to 20 minutes. How would you manage an AUS in a patient with a need for prolonged catheterization, hematuria, and or a bladder tumor? Think about it, right? Prostate cancer, we just saw there are thousands of men that get prostate cancer. A very small proportion of men have refractory, awful stress incontinence. They graduate to an artificial sphincter. Many of them have been radiated. And radiation does have a side effect of a delayed side effect of developing bladder cancer in patients. So you're going to have a proportion of patients with an artificial sphincter that are at risk, if they've been radiated, of developing bladder cancer, if not just a novel bladder cancer to begin with. They're also elderly patients. Many of them go for like a hip replacement or some other surgery. They develop a kidney stone. They need procedures as well. So this, if you were raising your hand, you are going to likely have to contemplate this in the course of your practice. But AUS is super specialized. We don't have a good contemporary series that looks at this, but if you look, just recently, Jaspreet Sandhu out of Memorial Sloan Kettering did an assessment. The AUS has been around for over 50 years. And back in the 70s, there was maybe, three surgeons that did one AUS a year. Back in the year 2005, 90% of surgeons did the majority of AUS, and only 8 surgeons did over 20 AUS per year. Now, this 8 number is probably slightly higher, but it's not dramatically higher. So most AUS surgeons aren't doing a dramatic amount of AUS. Most AUS surgeons are doing, a handful of AUS. And I would say that's fine, but all urologists deal with AUS patients, right? And that's what this, very scientific poll I did at the very beginning of this talk hopefully shows. So let's take an index case, 75-year-old male patient, had a radical prostatectomy, had adjuvant radiation. This was all done 3 years prior, has persistent stress incontinence, is gravitationally incontinent, no hematuria, has a negative cystoscopy for bladder neck contracture. The plan is for an AUS. So this is probably the oldest video known to man made by Boston Scientific, but I love the video because I talk through sort of how I think about it. The cuff is pressurized to squeeze the urethra as a tourniquet. The pump is placed in the scrotum. The balloon is by the bladder. And, you have urine that's being held back by that cuff. When the patient has the desire to void, they're squeezing it, the cuff is opening, the patient is peeing. After the patient's done peeing, the pressure-regulating balloon passively moves fluid back through the pump into the cuff tightens. So the cuff is really a key piece here that manages urinary flow back and forth, and it exerts a level of pressure around the urethra. It's a key point. That's going to keep coming back and forth to this case and to this talk. So you go back to the case, the patient undergoes a 4-centimeter cuff and has a standard PRB. So the standard PRB is 61 to 70 is the standard PRB. Initially does very well. 6 months later, develops gravitational incontinence again, has urodynamics. It confirms stress incontinence only. There's no overactive bladder. You do a cystoscopy. I will say, it's a key piece of what I'll try to talk through for this talk is, you really should be doing a lot of cystoscopy in people with an artificial sphincter if they have a voiding issue. If there's a voiding problem, you really should reflex to cystoscopy. And honestly, this cystoscopy was done before the urodynamics, to be very fair on it. Cystoscopy is done. This is the cuff site. This is the cuff site. So the cuff isn't greatly, coapting. And years ago, I was, at the forefront of really pushing an argument. And you realize how we go circuitously in medicine, where we say something and then we go later and change what we said, years ago. So historically, I pushed this idea that really the 4 centimeter cuffs in certain people might be loose, and we really should try to place smaller cuffs. We published another series on this, and then we find really 3.5 centimeter cuffs, which were released by Boston Scientific, actually cause a lot of harm in the radiated patient. And most radiated patients are the ones that are getting artificial sphincter. You might have a non-radiated patient that graduates to a very small cuff, but generally, small urethras get small cuffs, but small cuffs and small urethras normally don't do well. There's also another paper, Jeff Lodoyle out of USC had a nice series that really showed that small cuffs actually have huge rates of mechanical malfunction too. So I've largely gone away from the 3.5 centimeter cuff. We've taken them out. We don't really put them in, is what I would say. So I would say that to you too, that, consider some of the data that's been done in this field, that we started sort of pushing it, then we were the first ones to also say maybe, step away from it. Erosions are feared though, and that's the reason why I've sort of stepped away from aggressively putting tight cuffs around urethras. Once you get an erosion, it's a problem. And I'll show some data as to why it's a problem. Naturally, though, once you get an erosion, you can say, hey, there's a small hole, just put a few stitches in it. We've published that. You do a quick sort of urethral reapproximation. What are you losing? Because that's what it looks like. It's not that easy to just go and say, oh, we'll just pull out a cuff and, put a few stitches in it. It's a little bit of a disaster scenario. We would still undertake sort of closure of the urethra, but it's not easy. It is not easy. And so I would say, if that happens, try to put some reapproximating stitches, but it might not be doable, and you might need to leave a catheter for anywhere between 4 to 6 weeks or longer. And then that becomes, a problem for the patient and a problem for you in your practice. So why do erosions happen? If you look at the urethra, the dorsal urethra is incredibly thin compared to the ventral urethra. I gave some talks earlier at this conference talking about dorsal grafting. We will open the urethra dorsally and place a graft. A lot of people also open the urethra ventrally, place a graft. You can see the blood supply ventrally is quite robust. And naturally, if you place a cuff around a urethra, you would think the erosion site is dorsal. We don't have great data to prove if that's true or not, other than maybe this paper that showed, no, the cuff erosion site is ventral. It's ventral. And that's sort of crazy to me. But if you look at a heat map of numerous patients that have had erosions, many of them actually erode ventrally. That's crazy, isn't it? And if you think about it more, why is that? It's probably because the cuff exerts an amount of pressure on the urethral wall that leads to the event. It doesn't happen to do with sort of how thick one area of the wall is over another area. And I talked about this in a panel discussion several days ago. A lower pressure regulating balloon just exerts less pressure on the cuff and results in lower rates of erosion. So this was a series where they looked at high-risk patients that are at risk of erosion, like prior urethroplasty, prior AUS, prior erosion, and said, what if we put a smaller pressure regulating balloon or lower pressure regulating balloon, will we have better outcomes? And this is a huge series out of USC. USC probably has the largest AUS practice in the world. And so they put this out and said, the lower pressure regulating balloon actually does well. And for these types of patients, let's agree, erosion is problematic. It creates an environment for stricture to form. It prevents future AUS placement for some people. It creates a level of sort of angst for you and your patient. And most importantly, it creates ischemia at that cuff location. So it prevents or it risks a future cuff if you're successful. Why do I know that? This is a nice series that looks at many patients that have had sort of adverse outcomes following an AUS, and they showed that radiation, huge risk factor for erosion. But here's some of the other risk factors. Prior erosion, like I talked about, prior urethroplasty, like I mentioned, and Foley trauma. So remember the index question. I was talking about that patient that presents that you then have to manage. Once you place a Foley, there is risk. There is risk. So all of that contribute to it. And what is the risk? You know, erosion, I would say, is awful. And it's awful because if you look longitudinally at many, many, many patients that have had an artificial sphincter erosion, up to a third of them graduate to a urinary diversion. They don't necessarily graduate to a urinary diversion immediately after an erosion. It's the sort of delayed effect of having profound incontinence that usually just gets worse and worse and worse. Their urethra isn't able to accommodate more over a period of many years. And over many years, they then graduate to diversion. So erosion is problematic, and it creates a fork in the road. So once you hit erosion, you have changed the course and the fate of that patient. And it's not you, it's just that, you know, the condition has changed the fate of that patient. So next case, 76-year-old patient, had a recent ER visit, artificial sphincter placed 3 years ago, has a 4-centimeter cuff, had a traumatic Foley catheter placed due to a hip fracture. You see the patient for void trial 1 week later and you remove the Foley. This happens all the time. Again, we have to go to cystoscopy. Cystoscopy is the key to this. You do a cystoscopy, this is what you see. Is that an erosion? Who thinks that's an erosion? Raise your hand. Who thinks that's urethral trauma without an erosion? Raise your hand. I agree with Dr. Andriol. The 1 or 2 people. What's the only way I'm going to know that? What's the only way I'm going to know that? The only way I'm going to know that is if I make an incision and learn. I'm not going to know it. I'm going to suspect what I'm going to suspect. So we might not know the answer. The only way is to sort of either wait for it to erode and become really bad, or make a small incision and find out. Another option is you can keep the patient deactivated and wait several weeks, but then you're scoping again. So you can't just go to a period of deactivation and then just activate. You have to sort of deactivate and scope. It has to go back to scope. Scope, scope, scope. So this patient did not have an erosion, and we just moved the cuff. We moved the cuff. So there's several examples where we've shown where you can just move the cuff. And always, for some reason, I found that you're able to get it a little more proximal or slightly distal. And the way to test is to just irrigate the urethra, perhaps. You don't need to necessarily scope it when you're in the OR. You could just take the cuff out, irrigate the urethra, and if fluid comes out, you have your answer. Now, let's take a new case. This gets to the crux of what we're talking about. 75-year-old had a prostatectomy in 2013, had salvage radiation, is an awful leaker. In 2025 now, has a 4.5-centimeter cuff. This year, presents with gross heme. The patient's uncomfortable. Before you take the patient to the OR, a CAT scan is done. The patient had their AUS deactivated, and they had a catheter placed, but there's a lot of this in their bladder. So either that's a tumor or that's a clot. There's been some irrigation into the bladder, so you can see all that air. What do? What's your plan? How do you manage that? What do you do next? So here's some options. A, deactivate the AUS, then put in a rigid cystoscope and do a clot evac. B, remove the AUS entirely and scope the guy. C, SP tube. D, remove the cuff only and put in a rigid cystoscope. E, transfer. E, transfer, right? I like to say there's no correct answer. There probably are some correct answers here, and there are probably some less correct answers. So let's talk through it, all right? So you can ask, does transurethral manipulation of a cuff matter? This is the only paper that's been written about patients that have undergone transurethral rigid cystoscopy or flexible cystoscopy in patients with bladder cancer. So AUS patients can develop bladder cancer. This is the only series. They looked at 30 years worth of patients at the Mayo Clinic, and look at that. Bladder cancer patients over 30 years had a median of 2 diagnostic cystoscopies. What bladder cancer patient only gets 2 diagnostic cystoscopies after a diagnosis of bladder cancer? No one. So is this a great paper that we could use to sort of make our assumptions on this patient population? Probably not the best paper. It's a good attempt, but it's probably not the best paper. So we simply don't have enough data to know the effect of rigid scopes on the artificial sphincter cuff. So we have to extrapolate from what we know about catheters. So let's think about catheters. I asked the question, can we just deactivate it? That should be enough, right? We talked about deactivating the cuff. This is the only study that's been done looking at prolonged catheterization. And once you place a catheter for more than 48 hours, the fate of that cuff is sealed. The blue line represents patients that did not have a catheter placed. The green line represents patients that had a catheter for greater than 48 hours. The AUS fails, all right? The AUS fails. Dismal survival. So I would say that if you know a patient is going to have a catheter for more than 48 hours, you probably don't want to get them into the situation of erosion potential. Because hopefully I've convinced you, an erosion creates a fork in the road. That patient's fate is changed forever. So there isn't great data. I told you about USC. We do a lot of AUS. Duke as well does a lot of AUS. The three of us sort of came together recently and said, listen, I don't think this has really been clarified. We should try to clarify management and some practice recommendations. And recently we published this in the Journal of Urology. And we tried to come up with a little bit of an algorithm here. So if you are doing a flexible cystoscopy and or a rigid cystoscopy, and it's an under 21 French sheath, or 21 or less, and that's what you've planned. Deactivate the cuff, perform the procedure, reactivate the cuff, and move on. However, if you're planning to put a resectoscope in a patient for any reason, like for a clot evac, or if you only have large scopes in your center, and you're going after a stone even, it's a lot of trauma to this cuff. It's a lot of trauma to the cuff. And so I would recommend, and this, with multi-institutional recommendation, now in the Journal of Urology, unbuckle the cuff, make a small perineal incision, perform your procedure. And what do I mean by unbuckle the cuff? It's peel the tab. Move the tab over, do your procedure, close it, and then close the perineum, meaning rebuckle the cuff and then close the perineum, all right? But if you're planning a TURBT, clot evacuation, prolonged catheterization like the man that we're talking about, that's a different scenario. Remove the cuff, tie off the tubing, leave a catheter in, leave a catheter in, and then you leave it in for weeks. Do whatever you need to do, manage the patient. And then later, you can always either do it, have someone in your team do it, or send it to someone who you think can do it. But ultimately, you don't want to put the patient in the setting of perhaps going down the road of erosion. So if you go back to this case, think through that. When you see that initially on CAT scan, what are the chances that that patient is going to have a catheter for more than 2 days? I would say it's more than 0%. In this case, it's more than 0%. I would say it's more than 50% that that patient's going to have a catheter for more than 2 days. So that's how I would recommend that. And also discussed in panel, several days ago, we've talked about the concept of just taking a piece of tape or a Penrose and sewing that together and preserving the space. Also published in the Journal of Urology. Also, I think protects you from a sort of practice standpoint in preserving the space so that you don't have to really manipulate the urethra much at the time of a revision. Okay? So, in closing, remember AUS cuffs are pressurized. Use cystoscopy to evaluate it. Avoid any situation that might promote an erosion. And unbuckling the cuff can be done with Bovie and very minimal bleeding. All right? Thank you.